So the spectrum of acute coronary syndromes. There is deposition of plaque in the coronary arteries, that is atherosclerosis. There can be partial occlusion of the coronary arteries leading to stable angina, chronic stable angina. Sometimes the plaque can rupture and there can be thrombus formation and subocclusive intracoronary clots, which leads to unstable angina. And complete occlusion of the coronary artery will result in myocardial infarction. So this is the spectrum of acute coronary syndrome. The unstable angina and MI, both STEMI and non-STEMI, they are acute coronary syndromes, while this chronic stable angina is different entity. Stable versus unstable angina. As we can see here, in stable angina there is a fixed stenosis, while the unstable angina there is a dynamic stenosis. So clinical features in stable angina, there is demand-led ischemia, that is the ischemia that the pain increases with stress and it is related to effort, and it is predictable that the patient knows that this much workload, this much effort will lead to chest pain. Symptoms are long-term. While in unstable, the supply-led ischemia is there, suddenly the supply is impaired, so symptoms at rest also can be there. It is unpredictable and symptoms develop over short term. Risk assessment. In stable angina, symptoms on minimal exertion, exercises testing should be done, duration of exercise should be seen, a degree of ECG changes has to be assessed, and there can be abnormal BP response. In unstable anginal patient, usually there are history of frequent or nocturnal symptoms. At rest, the ECG changes can be there, and the ECG can change with the symptoms, and there is elevation of troponin. While in stable angina, there is no elevation in the cardiac enzymes, cardiac troponins. Unstable angina, these ischemic episodes, they occur more frequently, more intense, and last longer. And they are precipitated by less activity, or they can be precipitated even at rest. So it is not effort related, while stable angina is predictable, it is effort related. Unstable angina can progress to acute MI due to presence of complicated coronary lesion with ulceration, hemorrhage, or thrombosis at the site of atherosclerotic plaque. The lesion may heal, and when this happens, the sign and symptoms return to more stable pattern. Unstable angina is a medical emergency, and during episodes of angina, there is transient ST segment shifts or T wave flattening, or there can be inversion, T inversion. Signs of LV dysfunction may accompany the ischemic episodes, so we can get pulmonary rails, there can be audible S3, and we can have a murmur of mitral regurgitation. Therapy is directed towards reducing myocardial oxygen demand with increased coronary blood flow. So antiplatelets and anticoagulant agents, they are used. Coming to acute myocardial infarction. Myocardial infarction, clinical syndrome resulting from occlusion of a coronary artery with resultant death of cardiac myocytes in the region supplied by that artery. When these patients present in emergency, they have ST elevation in ECG and so are referred as ST elevation myocardial infarction, that is STEMI. Wide range of clinical sequelae varying from a small clinically silent region of necrosis to a large area of infarcted tissue resulting in cardiogenic shock and death can be there. Etiology. MI is due to prolonged myocardial ischemia. So leads to irreversible necrosis of the heart muscles. 90% due to acute thrombus at the site of underlying coronary atherosclerosis. There can be non-atherosclerotic causes also, cocaine use, because here due to the ability of cocaine to increase the myocardial O2 demand, and also it induces coronary vasospasm and promotes coronary thrombosis in association with platelet activation and endothelial cell dysfunction. Risk factors again, as the risk factors of atherosclerosis. Here also, age, male gender, smoking, dyslipidemia, diabetes, hypertension, abdominal obesity or lack of physical activity, low daily fruits, the daily dietary intake of fruits and vegetables that is low, and psychosocial factors. These are all the risk factors for developing MI. Clinical presentation. The initial diagnosis can be made on the basis of presenting history, physical examination, and ECG. The most common signs symptoms with a patient present with are there is an abrupt onset of chest pain, or there can even be just neck or jaw discomfort, felt as pressure, burning, or squeezing in character. The pain radiates to the jaw and to the umbilicus, lasts longer than angina. That is more than 20 minutes. If the pain is persisting, then it is not just anginal pain, but it should be considered the possibility of myocardial infarction. It's more intense. There can be nausea, diaphoresis, dyspnea, and feeling of impending doom. Circadian variability. Most commonly, it's been seen that the episodes, the events of MI, they occur most commonly in the morning hours, soon after awakening. Symptoms usually begin while at rest and only occasionally are brought on by physical exertion, in contrast with the stable angina, chronic stable angina. Some patients, they have less pronounced symptoms, just they can feel generalized weakness, dyspnea, and indigestion, and these are the patients who can be misdiagnosed as some dyspepsia or something else. 20% of the cases, they have no signs or symptoms, and they are only detected on when we do ECG. There are changes of acute coronary syndrome on the ECG. Precordium is usually quiet. Common physical findings in myocardial infarction, they relate to the impaired left ventricular systolic and diastolic function, associated inflammatory responses, and stimulation of the sympathetic and parasympathetic nervous system. Differential diagnosis: acute pericarditis. Here the pain increases with inspiration, while that is not so in cases of MI. Similar presentation can be in patients with pulmonary embolism. Acute aortic dissection. Here the pain is usually very severe, and there is much radiation to the back, and there is characteristically unequal peripheral pulses. There can be costochondritis. Esophageal rupture also can present with sharp squeezing and pain, retrosternal, cafe coronary. So all these are differential diagnosis of myocardial infarction. Lab findings, that is investigations, assessment. There are 4 groups: ECGs, cardiac biomarkers, imaging, and angiography. So these are the 4 major things we have to evaluate. Coming to electrocardiogram, there can be Q wave infarction. Initially, hyperacute T waves can be there, and ST along with ST elevation in the leads overlying the involved myocardium. As the cell death occurs, there is loss of the R wave and progression of Q wave development. The T wave begins to invert, followed by return of the ST segment over subsequent days. So initially there is hyperacute T waves, then ST elevation is there, and as the necrosis progresses, there will be appearance of Q waves, and then the ST will gradually settle down. The T waves, they may remain inverted for weeks to months, and the new Q wave, they persist permanently. Posterior wall infarction. Here the mirror image pattern in anterior chest leads. So when we see the anterior chest leads, if we see the mirror image of this will look like as an ST elevation MI. So this is an indication of posterior wall infarction with initial ST segment depression. T wave inversion can be there, and development of tall R waves in lead 1 and V2. So these are all posterior wall infarction signs. Non-Q wave infarction. There can be new ST depression along with this T wave inversion, and persisting for 48 hours or longer in leads overlying the infarcting segment. So there will be ST depression along with T inversions, which will persist. This is non-QA infarction. Then bundle branch block, diagnostic ECG evaluation may not occur, and diagnosis of MI relies on presence of serum markers and lab modalities. In here, it is many times difficult to diagnose MI, but there are few criteria we'll be discussing later. So here, serum biomarkers are very helpful. This is a picture ECG of anterior myocardial infarction, where we can see that there is gross ST elevation in the anteroseptal and lateral leaves, along with T wave inversion in inferior leaves. This is an inferior myocardial infarction, so we can see the ST elevation changes in the inferior leaves, that is 2, 3 and AVF, and there is T inversion in the lateral precordial leads. This is again anterolateral wall myocardial infarction, so lead 1 and AVL are also showing ST elevation along with the V2 to V6. Coming to serum markers of infarction, that is cardiac biomarkers. Certain proteins are released into circulation when there is necrosis. So first is creatinine phosphokinase, that is CPK. It is also can be seen in muscle and brain diseases. So it is specific, not very, but there is a MB portion is much more specific for heart diseases. So the CKMB rises in plasma within 4 to 8 hours, and it peaks at 24 hours and gets to normal by 36 to 48 hours. The serum CKMB isoenzyme should be measured on admission, and then 12 and 24 hours later in the diagnostic evaluation of an acute MI. This is not influenced by skeletal muscle injuries, the CKMB portion. And it can be elevated also in myocarditis after surgery, in hypothyroidism, and in cases where repetitive cardioversion had been attempted. Troponin I and T, they are very sensitive and they are highly specific markers of acute MI. The levels begin to rise within 3 hours after onset of infarction, and it remains elevated for several days, along about a week. Higher tropi levels or early presence of troponin T assays correlate with greater short-term mortality. Third is myoglobin. Myoglobin is released into circulation very early after the myocardial injury, and it is can be detected within 2 hours of infarction. However, there is rapid renal clearance and it has a low specificity, so the use is limited in diagnosis. Lactate dehydrogenase. This also rises within 24 to 48 hours of MI, peaks at 3 to 5 days and returns back to normal, that is baseline levels, by 7 to 10 days. This is usefulness in the patients who are admitted to hospitals 2-3 days after onset of symptoms. And level of LDH1 is greater than LDH2. This suggests myocardial necrosis if the proportion of LDH1 is greater. Non-specific reaction to myocardial injury is associated with a polymorphonuclear leukocytosis, which appears within a few hours after the onset of pain and persists for 3 to 7 days. So the white blood cell count increases and often reaches levels of 12,000 to 15,000 per ml. So it need not to be infection, but it is because of myocardial injury itself. There is a response to myocardial injury. The ESR rises more slowly than the white blood cell count, peaking during the first week and sometimes remaining elevated for 1 to 2 weeks. Management. Pre-hospital care. The prognosis in MI patient is related to 2 general classes of complications. There can be electrical complications, that is arrhythmias, and mechanical complication, that is pump failure. The care of these patients includes early recognition of symptoms and seeking medical attention as early as possible, emergency medical team for resuscitative maneuvers and defibrillation, transportation facilities to hospital for managing arrhythmias and providing advanced cardiac life support, and reperfusion therapy. Management in the emergency department. Stat doses, as we commonly say, is giving dual antiplatelet therapy, that is aspirin 325 milligram along with clopidogrel 300 milligram along with atorvastatin 80 mg. That has to be given stat as soon as it can be given to the patient who is presenting and is suspected to have MI. Oxygen should be administered by nasal prongs or face masks at the rate of 2 to 4 liters per minute for the first 6 to 12 hours after infarction. Up to 3 doses of sublingual nitrate 0.4 mg. They should be administered at about 5-minute interval to relieve the pain, but if there is hypertension, they should be avoided as they can precipitate shock. IV morphine 2 to 4 mg is very effective analgesic for the pain and can be repeated every 15 minutes, but BP should be monitored. Coming to management strategies, pharmacological or mechanical reperfusion. So primary PCI and fibrinolytic agents. Primary PCI, either the stents can be bare metal stents or drug-eluting stents, or we can use fibrinolytic agents. Fibrinolytics activates the natural fibrinolytic system and dissolve the responsible thrombus. They reduce the mortality and recovery is improved. Streptokinase K, tissue plasminogen activator, alteplase or TPA, and modified plasminogen activator, that is retiplase or RTPA, they all can be used. Antiplatelet and anticoagulant therapy, they are used to maintain patency of the coronary vessels following thrombolysis. So the anticoagulants that are used are, we can use unfractionated heparin or low molecular weight heparin, then fondaparinux or direct thrombin inhibitors like bivalirudin can be used. Coming to the late management of MI. So after risk stratification and further investigations has been done, we come to the management, lifestyle modification, that is cessation of smoking, control of modification of diet, weight control, dyslipidemia control, regular exercises, all these should be included in the management strategy. Then secondary prevention, drug therapy, antiplatelet therapy including aspirin and or clopidogrel, additional therapy if there is presence of diabetes or hypertension, beta blockers, ACE inhibitors or ARBs, they should be included in the regime, and statins. These all part of secondary prevention drug therapy. Then rehabilitative devices like implantable cardiac defibrillator in high risk patients. Coming to complications of myocardial infarction, there can be arrhythmias, there can be heart failure, patient can go into cardiogenic shock if LV dysfunction is severe. There can be sudden death because of massive MI. Reinfarction, extension and expansion of infarction can be there. Then infarction of the papillary muscle of the mitral valve can result in mitral regurgitation and congestive heart failure later. Rupture of interventricular septum can be there and leading to ventricular septal defects. There can be formation of presence of thrombus in LV causing peripheral embolism later. There can be cardiac rupture also. Deep vein thrombosis in legs causing pulmonary embolism. There can be pericarditis during massive infarction. Aneurysm of ventricles can be there along with thrombosis and thromboembolic phenomena. Then Dressler's syndrome, that is a post-myocardial infarction syndrome, can be there. Prognosis, in almost 25% of all cases of MI, death occurs within few minutes without medical care. Half the death occur within 24 hours of onset of symptoms, and about 40% of all affected patients die within the first month. So the mortality is very high. So we should be very vigilant and very aggressive in treating these patients and also identifying these patients. So awareness programs are also needed for this, so that everyone is aware what are the signs of MI, and they should uh, come to the hospital care as soon as possible after suffering any cardiac chest pain. Thank you.